You see patients because you've recently actually had a wonderful set of papers talking about this. How do patients kind of typically come to the office when they come to see you and explain the kind of pain that they have that would allow you to determine or start to think about, well, do they have a lot of these chemical issues like migraines or tension headaches, or do they have neuralgia? How do they discern that?
Yeah, so I think first of all, it's important to understand that no matter what headache diagnosis you have, Zeev mentioned, three of them, but there are others like dorsalgia or cervical headaches, or maybe trigeminal neuralgia or occipital neuralgia. Those are all headache disorders. And no matter which disorder you have, you can have nerve pain. And I will explain to you how to understand a little bit better if what you're experiencing is nerve pain. So first of all, typically, there is a starting point that you can identify with one finger. So for example, a lot of my patients have pain in the back of the head, and the pain might start in this area, in the hair-bearing area, but it could really be anywhere along the back of the head, and it doesn't have to be on both sides. It could just be on one side. Or the pain starts right here at the medial brow or somewhere at the temple. So it's important that you can pinpoint where your pain starts. The other thing that's important is that your pain radiates in the trajectory of the nerve. And so what we like to do is we actually like to ask you to draw your pain, because it can tell us a lot about your symptoms, and it can help us differentiate between nerve pain and a migraine or a headache. So for example, when we speak about occipital neuralgia, which is a very common type of nerve pain, the pain often starts here in the back of the head and then radiates to the front to either the forehead or behind the eye. That is a very typical sign of that you're suffering from nerve pain. But you could also have pain that starts here at the eyebrow and radiates either upward on your forehead or downward towards the eye. And you may also have pain in the temple that can radiate either towards the eye or upward toward the temple. So all these drawings here on the right side are drawings of nerve pain. When you look at the drawings on the other side, that are very diffuse, and we can't really see a starting point and we can't really see a radiation pattern, that is more indicative of having probably a chronic migraine, maybe a more central problem, but probably not a nerve problem. So this is a good way to understand better if you're having pain, nerve pain. Now, but I will say it's very important to be evaluated by a specialist who understands nerve pain very well, because it's not always so simple and not always so clear. So even if you feel like your pain is everywhere, we might be able to help you, identify your pain points and do something called a nerve block to determine whether it's really nerve pain. The idea behind it is that we use a local anesthetic right where your pain starts or is, and we numb the nerve. So essentially, the nerve cannot feel anymore. And if your pain goes away when we do a nerve block, the likelihood of you having a nerve problem or nerve pain is very high.
Now, is that something, because you've recently published about this and you just kind of showed the slide, which I think is so critical and really important. These are not always very clear cut, as your images here show. And so oftentimes that, can kind of lead to a delay in seeking at least an opinion on whether or not your problem is caused by nerve. And you recently actually published a paper on this. Can you talk a little bit about that?
Yes. So, what we see very often is that patients with nerve pain get diagnosed with migraine or tension headache, um, but they don't get worked up for nerve pain. And so they're not treated for nerve pain. And when I look at the group of patients that I've treated and other surgeons in the United States have treated, the delay between the start of symptoms and the point where they're evaluated by a nerve surgeon is 19 to 20 years. And that's just too long. We really have to do better because nerve pain is treated very differently from migraine and headache. So it's important to identify whether you have migraine or headache or nerve pain, or maybe a combination of these things, because then we can better help you.
Yeah,
And
and I think there's also, and sorry to interrupt, if I'd love to hear your opinion on this. You know, when we talk about nerve pain in the extremities, meaning the arms or legs, which people have talked about for decades, in contrast to nerve pain causing headaches, we have known that if you have pressure on a nerve, so there's a compression of a particular nerve, typically the sooner you address that, the better, because the longer the compression is present, the more damage occurs to the nerve and the harder for it to recover. Do you find, have you seen that in your patients as well in the headache, nerve pain population?
yeah, so this research hasn't been published, but it's about to be. So it appears that if your symptoms have been present for less than 3 years, you do better with nerve decompression than if your symptoms have been present for over 3 years. Now, we still see very good results in patients who've had symptoms for over 3 years. So I don't want to discourage anyone from having a nerve decompression at that point, because we see that even patients who have had symptoms for 20 years or 30 years have very good outcomes. But certainly we see a very slow downtrend on improving symptoms when symptoms are present for a very long time.
Yeah.
So that's why it's very important to see a specialist as early as possible to get on the right treatment path.